Again, good evening, everyone. So tonight, our topic is all about clinical monitoring. And again, I'm Dr. Chris Guzman from the Philippines, and I am currently the course director for Smartee Clear Aligner Philippines. I've undergone trainings and workshops at DP Dental in Singapore for my functional training, Invisalign treatment, sleep medicine and airway issues, and TMD pain management. My husband's also a dentist, and we are doing our practice here in the Philippines. And currently, we are doing trainings for doctors to be a Smartee provider. Let us first discuss on the Smartee Clear Aligner. So Smartee Clear Aligners are produced and manufactured in Shanghai, and they also produce their own aligner sheets. From a single layer sheet, they have innovated to a multi-layer sheet using the Diamond 2 material. And before they have released it, they checked its combination of soft and hard material for better consistent orthodontic force, and it also underwent the mechanical property testing of sheets. They also used the 6-axis force transducer to precisely measure the aligner force and torque in 3 dimensions to better assist in aligner staging. And they have different product options, from the general or the basic one to the Smartee Alpha, which has daytime and nighttime aligner. They also have the Smartee GS, which has the mandibular relocation system, and the Teen and Kinder. For Smartee GE, they have the Mini, the Light, Express, and Infinity packages. If you will notice, all of these packages have refinement. And later on, we will be discussing on refinements, when do we use it, and is it really important? Now, the second product, the Smartee Alpha, was developed because recent studies have shown that there is a correlation between the growth and remodeling of condyles with the human circadian rhythm, as well as the orthodontic pain associated with the orthodontic treatment and with the human circadian rhythm. That's why they came up with a daytime and nighttime aligner for efficiency compensation during the nighttime. And just to show you how it is compensated, it adds 1 degree movement per stage. So the expression of movement per aligner is 65%. If you will multiply that by 2 degree, for example, for stage 1, you will be getting a 1.3 degree movement, having a 0.7 degree at rest position. So in incorporating the nighttime aligner, it adds 1 degree movement, making it 3. When you multiply that with the expression of movement by 65%, you are getting only 0.05 degree at rest position. So that only means that by using the Smartee Alpha, you will be making 50% faster result for your treatment. Now for the Smartee GS, you avoid or reduce having tooth extraction or surgery because we are repositioning the mandible. We are doing orthopedics and orthodontics simultaneously, and that avoids risks of extraction and surgery, as well as we are improving the facial profile of our patient by doing so. Now, in their mechanism, they use the Smartee solutions. Now, for the general one, they use S1 to S7 solutions, which has the tooth extraction protocol and also the distalization protocol. They also have their patented intelligent rotation center to ensure that there is no risk with bone cracking or fenestration. They will be adjusting the rotation center in such a way that there will be no risk with teeth movement. Now, S4 is the intelligent power arm and TAD or mini screw in the event that there will be a need for a better anchorage for your treatment plan, then they will be designing this. S3 is the intelligent traction. Now, for this intelligent traction, you will be needing a button to place on the tooth for traction, and Smartee will be placing a precision cut for you to hook on the elastic for traction. Now, the S2 invisible lip bumper that is designed, that is to provide pressure on the lip. This lip bumper will provide pressure on the lip, and that pressure will be transmitted to the posterior teeth to strengthen anchorage, especially during distalization. Now for S1 classic attachment system, later we will be going back to the functions of each attachment and why they are important. Now for the Smartee Alpha, it also has the S1 to S7 technology, but it has also the S11 solution, which has the palatal device or a palatal cortical rods placed on it. It also has the S15 Smartee Hook traction device that supports all kinds of traction, whether it be a class 1, class 2, or class 3 elastics. And it also has the Smartee button. As for the Smartee GS, it can cover S1 up to S17 solution, which has the mandibular repositioning device with bike plane or with occlusal splint. It also has the device for mandibular advancement, like a twin block or a Herbst, similar to a Herbst appliance. And that is the SGHB and the SGTB. It also has the invisible forwarding traction treatment and the active mandibular positioning retainer. Now we will be discussing on the clinical monitoring, what it is that we need to observe or we need to monitor with our patient once we start the treatment using the Smartee system. Normally, when we receive the aligners from Smartee, it comes with this box. It comes with the casing for your patient. For your patient to put on the aligners, it also comes with the extractor tool so that it will help them how to remove it conveniently and easily, as well as the 2 chewies. So if you will see, it's comprehensive because it includes already these materials. It also comes with a treatment overview guide, so it will be showing on the steps on what you need to do and a special note on what you need to observe during the treatment. So for example, if you see here before step 1, you need to extract tooth number 28, then you have to do it first before you put on the first aligner. So step 1 is the first aligner or stage 1. Stage 13 is the 13th aligner. And if ever that you need to add attachment, there will be a template for you to put on the composite for attachment. You just need to follow the instructions on where to place it. And if ever that you need to add orthodontic button, then it will also be indicated as to which stage you will be placing it. And it also will be telling you what kind of elastics that you will be using on the special notes. It will show you when to place IPR. So for example, stage 13 or step 13, you need to place IPR, then please do not give aligner number 13 to your patient so that your patient has to go to your clinics for you to perform the IPR. There will also be a drawing here as guide for you where to place the attachment and the IPR drawing. So there's a guide for you where to place the IPR. You just have to refer to the treatment overview. Now, this comes in paper inside the box that you will be receiving, but you will also be having this information in your own Smartee account, in your Smartee system. Now, let us move to the clinical monitoring. A while ago, Fiona mentioned that it is very important for you first to have patient compliance, for your patient to be compliant in wearing the aligners. Second is to know the correct treatment procedure. And of course, we also need to know how to monitor our patients as we do the treatment with them. We have here a monitoring list or a guide on what we should do for patient compliance, how to check the fit of the aligners, the attachments, the fit of the next set of aligners. We also need to know if our patient is having good oral hygiene or observing good oral hygiene. We also need to check on the interproximal contact points. And when do our patients go back? Is it standard that we need to see them every month, every 2 months, or every 3 months? So we will be discussing all of these and how to closely monitor on the treatment effects. Once your patient receives the aligner and you have performed already the clinical operations needed, then we will be instructing our patients on the duration of wearing the aligners. The duration of wearing the aligners is every 7 days 10 days or every 14 days, but it is not standard. It depends on our patient's compliance. It depends on the age of our patient, and the patient should be wearing the aligners for at least 20 to 22 hours a day. Now, for me, what I do is I first provide 4 sets of aligners to my patient, and I will be giving them instruction to wear it for 10 days. Now, it will be 40 days after I see them. After 40 days, I should be asking if my patient is wearing aligner number 4 already. Now, if my patient is not wearing aligner number 4, for example, he or she says, I'm wearing number 2 or number 3, you will have to ask your patient, why? Do you wear your aligners as longer as possible? What are your challenges in wearing it? Because sometimes patients would say, I'm scared to wear it at night, or probably they're not using it at night, they're only using it during the daytime. You just have to assure them that there will be no problem in wearing it for 20 to 22 hours. Now, if they find it difficult to place, then you will have to instruct them how to place it properly and how to remove it correctly. Because initially, there will be a struggle in placing and removing the aligners. You will have to also help your patient, and because it is very crucial for the success of the treatment, for patient compliance. Now, for the intervals for each return visit, again, it is not standard. It depends if you will be doing clinical procedure to your patient. Like earlier, I showed you, there will be IPR, for example, IPR that should be placed on the 13th stage. Then you will have to see your patient before that stage. On the 13th stage, they have to come back for you to place IPR or probably place attachments again. Now, if your patient is compliant in wearing it and you do not need to see your patient for clinical procedure, then you can see them less often, like every 3 months. But if your patient initially is not compliant, then please see them at least once a month or every 2 months. Now, for oral hygiene, one of the advantages of clear aligner is that patients can remove it. There is no food restriction. They can eat anything they want. They just have to remove the aligners when eating, but then they have to be compliant in making sure that they maintain good oral hygiene. So we need to assess their dental health and gum problems, and they also need to be taught on how to brush their teeth correctly. They also have to make sure the aligners are cleaned well. Use the floss, as they can floss in between the teeth, as there is no restriction in using that. So that is very important. We do not want to have an excessive calculus because that can affect the tooth movement. It can also increase the risk of gingivitis and periodontitis, also increase the risk of the black gingival triangle. So even though that we are able to align the teeth, if we see these gaps or black gingival triangle, then that will not look good after our treatment. Now for the fitting of the aligners, we need to check if the aligners are fitting well or the aligners are fitting the entirety of the tooth. We also have to check the fitting of the attachments. For example, the patient, I have to see the patient after 40 days, right? Because I have given my patient 4 sets of aligners. Now, let's say my patient is compliant in wearing it, and my patient wears number 4, and she's done already with that set. I will be checking on the fit of that aligner. I will check if it fits well and if it fits the entirety of the tooth. I will also remove the attachment and check if, the aligners. I will remove the aligners and check the fitting if the attachments are still there. Later, we will go back to the functions and importance of those attachments so that we are aware and find it important for it to stay there. For the interproximal contact, we have to always check the tightness of the interproximal contact point. Now, if there is no IPR indicated on your treatment plan, we still have to check by using a floss. And if there is really tightness of the interproximal contact point, we have to reduce it or loosen it by using the diamond strip. So that will help in teeth movement, and especially for too tight contacts or rotated teeth. For attachment inspection, we need to check if those attachments have worn out or fallen off. And we have to put it back. We have to rebond the attachment right away once we find out that it has been detached. So again, let's go back to the importance of these attachments because it plays different functions, not only for retention, but it plays different functions for teeth movement. So attachment is made of the light curing resin made by the attachment templates. So once you receive Smartee, you will be getting sets of templates. There is a template for the etchant, and there's also a template for you to place the attachments. And that is bonded resin on the teeth using the composite. Now, the function of the attachment primarily is for aligner retention, but it greatly assists in teeth movement as well. If in your treatment plan, you see an ellipsoid attachment, that is to optimize for molar segment retention. So take a look at the before treatment, after the treatment, and where it was placed. So that is to avoid the aligner getting loose. Now, if ever you see on your treatment plan that there's a bite pads attachment, that is to correct the cross bite in case of scissors bite or to unlock the bite of your patient to prevent occlusal trauma. Take a look at this treatment before and then after the treatment and where it was placed in the animation scheme to unlock the posterior bite and prevent occlusal trauma. Now for window attachment, that's for teeth elongation. As shown below, in case of anterior open bite, those window attachments are placed to assist in extrusion and to correct the open bite. Precision control is for anterior root control and long distance canines translation. As shown below, we need that to achieve the good treatment outcome for root control. Now, this is especially important also when we do distalization that's placed on canines for root control. For vertical rectangular attachment, it plays two functions. First is to correct the rotation or for root control, especially for rotated teeth. And secondly is for anchorage enhancement. That is placed, for example, there is tooth extraction cases that we need to enhance the anchorage, then those rectangular attachments will be placed. And the horizontal rectangular attachment is for molar tipping and extrusion. If ever that your case would need molar tipping and extrusion or to aid in molar tipping and extrusion, you will see that horizontal rectangular attachment. And the iris attachment will help to intrude the anterior teeth, whereas the bite plane attachment will also assist with anterior bite, deep overbite, to unlock the anterior bite in case of deep overbite. When combined together, it can be used with intrusion to correct the deep anterior bite of the patient. So those are vital or important. So if any of those attachments falls off, then you will have to put it back or replace it. Now, the needed clinical operations for visit is, for example, you need to rebond the attachment that was debonded, or perhaps you need to place IPR in between the treatment, or if ever you need to place elastics in between the treatment, because elastics can be placed before stage 1, or probably you can place elastics in between your treatment. Now, for the guide, you will be taking a look at the treatment overview. So for example, before step 1, before you put on the first aligner on your patient, okay, can you hear me now? Yes, I'm so sorry. So you will be having this treatment overview guide as a guide for you on what to do step by step. So it is user-friendly, so you will just have to follow the step-by-step procedure. Now, the fitting of the next set of aligners, that is very important. You have to also make sure that the fit of the next set of aligners is good. Now, for example, the doctor is very busy, right? For example, he or she has a lot of appointments, and probably he sees that this patient that he will be seeing is just for issue of the aligners, and will tell the assistant to just give the aligners and not see the patient. Please make sure to see your patient to check if the aligners fit well, because your patient might not notice that the aligners are not fitting. So it's the doctor who knows if it fits well. For inspecting if the aligners are really for the aligners, it has to be, we have to ensure that the aligners are worn correctly. So it is very important that the patient knows how to wear it correctly, and it should be snug fit, because each pair of aligners plays a full part in its effectiveness, and careful inspection and reasonable treatment at each follow-up visit guarantees also a successful treatment. So with close monitoring on the treatment effects, the doctor needs to compare it with the 3D design. Yeah, you have an animation to check on the movement of the teeth, right? So you have to check if it's still the same with the condition or what you see on your patient. You have to focus on the intrusion, on the extrusion or derotation. For the posterior anchorage, sometimes if your case is complex, we suggest the patient to take the routine CBCT or OPG. We usually recommend CBCT or OPG so that we will be able to avoid the risk of fenestration or thinning of the alveolar bone. Although Smartee will always check on this using your tools or diagnostic tools like the OPG or the Ceph X-ray that we are submitting, with the movement of the teeth, we also have to ensure that we are monitoring them correctly, because there are untoward movements that we may not be able to predict. So attention should be paid to the design. And as for the mid-stage treatment monitoring, we also have to check what do we need to see when we do our troubleshooting. For example, for the attachment losses or aligners not fitting, if the aligners cracked or if there's poor retention. I've mentioned earlier how rigid the material is of Smartee. The material is diamond 2 and the triple layer sheet. Also have to check on the poor retention or the tooth movement issues. If there's joints clicking and aching on your patient, and we also have to check on the occlusion and the anterior open bite. So we have to have this troubleshooting list. Now, for the attachments, because it is only made of composite material, there's a question if attachments have a high probability of damage, or if the attachment wears out or is damaged, what should we do? When the patient is unable to attend the appointment, what will happen to the unbonded attachments? So those are the questions that we usually have in mind, right, when we place attachments. If ever the attachments wear off or wear out or fall off, you have to rebond it with the current attachment. For example, you are placing the attachments from the first stage and you have a template from the first stage. On the 13th stage, then the attachments are no longer there. You have to back it up with the last or the current aligners that the patient is using. So that is the one that you need to use. You cannot anymore go back to the previous attachment template. Now, how would you know if the aligners are no longer fitting? If the clinical manifestation is greater than 1 millimeter between the aligner and the teeth, then that means that the aligners are no longer fitting. So the entire aligner doesn't fit anymore. There are instances wherein the aligners are fitting well, but only about 2 teeth are not aligned. So you will have to check on the fit. Okay, I'm sorry for the background noise, but you will have to check on the fit of the aligner. Check if it's not fitting, so it's more than 1 to 2 millimeters. There are instances wherein only one doesn't fit. So for example, in this case, there is an accidental intrusion of the canine or premolar. It might occur if IPR is not done as recommended. Because there is no space for teeth movement, it might accidentally intrude. In those cases, then you will have to do troubleshooting by making your patient go back or rewear the previous one and extend the wearing time. But in the event that it's really no longer fitting, then that's the time that we will have to use the refinement already. So it's very important that we do these, IPR if that is recommended, or do the clinical procedure as recommended. So if there is no IPR, there might be intrusion of the premolar accidentally. So please observe on that. Now, number one reason for aligners not fitting is poor compliance or insufficient wearing time. Therefore, the aligners are not functioning. Or probably individual tooth movement differs. In clear aligners, Smartee will be producing an animation of a predicted movement per stage. But of course, those untoward movements or tooth movement that differs cannot be predicted. And in those cases, we will have to resort to refinement. Smartee will be producing new aligners from the time that it's not fitted, and they will be part of the package that you will be getting. So the solution for that is to actually ask your patient to go back to the previous aligner, the one that fits well, and let them extend the wearing time by 3 to 7 days, and also increase the chewing time with the aligner seaters. Every time your patient wears the aligner, they have to use the chewies to bite on to ensure that the aligners fit well and to maximize the full effect of teeth movement. Now, if none of the aligners are fitting, for example, your patient cannot wait for the new set to come or for the refinement sets to come, then you can make use of the auxiliary elastic. You can do this technique for the aligner to stay put, and then you can continue on wearing the next stages. But if the above method does not work, then you need to retake the impression or take the new oral scan and submit for refinement. Smartee will redesign and produce new aligners for your patient. Number two reason for aligners not fitting is that there's no space for teeth movement. So again, we mentioned about no space. We need to help them by doing the diamond stripping or using the diamond strip to reduce the space or correct the interproximal contact point, to loosen the interproximal contact point. Okay, so again, if none of the above method works, then we have to do refinement. You can also use auxiliary elastic or have your patient go back to the last stage or previous aligners. Number three reason for aligners not fitting is during a long period of treatment, the attachment will wear out. For example, your patient treatment plan has attachments placed from the first stage. And after a year, of course, it might wear out. Then you will have to rebond the damaged attachment. If, for example, you are given a vertical rectangular attachment and you see that it's no longer vertical, it became like a square one or it has worn out, then you have to remove the entire attachment and place it. You have to etch it again, you have to do bonding, and then you have to use the current aligner. The current aligner means the one that fits well. So if ever the current aligner is not fitting, of course, you cannot use that as template for you to rebond the attachment. You have to go back to the previous aligners that fits well with your patient, and stay there for about 3 to 7 more days. Let your patient wear it for 3 to 7 days and increase the chewing time. Or else you have to do refinement if that method is not working. I've mentioned about the rigidity, the flexibility, how durable the aligner is. Because it's triple layer sheet, it still might crack. Because if you will be reaching the extent of its elasticity or flexibility, it will still crack. Usually, the reason for aligners cracking is that the patient is not wearing it correctly, and now it breaks. Now, what do I mean by the patient not wearing it correctly? If the patient will use the chewy to bite on to seat the aligners, then by all means, it will really crack. So the patient should put first the aligner, make it snap on the tooth or on the teeth, and then use the chewy to bite on. So that will prevent cracking. And if ever that they will be removing the aligners, you also have to teach them how to remove it correctly by using the extractor tool. So first, they have to access it from the inside. On the upper, they have to access it from the palatal side. If it's the lower, they have to access it from the lingual side. Once they pull it off on one side, they have to pull it on the other side. And when they remove it using their hands, they have to be careful and not forcibly remove it. Their hands or fingers should also move as they lift the aligners from the teeth. And number two reason of aligners cracking, if the retention force of the attachment is too strong. For example, there are a lot of attachments placed, or perhaps there are a lot of attachments for retention. Then you can just remove one or two of those attachments for retention for the moment, so that there will be ease of removal of the aligners for your patient. Or probably your patient has a severe malpositioned teeth, too much flare or too flaring or too flared teeth. There will be a large undercut. Or probably the dental crown is too long and there's a large undercut. Then if that's the case, we use less attachment. Remove the non-essential ones, but not the essential ones, because we know already the functions of them, how important it is. Let's not remove the functional ones. Now, if ever the teeth or there's flared teeth, please block out the undercut, trim off the aligner appropriately. Number three reason of aligners cracking is for patients who suffer from teeth grinding or bruxism. Now, there will be times when patients might resort to bruxism because they will be finding the aligners as irritant, for example, but not all patients. Then we need to order additional set if the next set of aligners are not fitting. Sometimes that bruxism will develop in time. It's not overnight that they will be having cracked aligners because of bruxism or teeth grinding. For example, if it happens after the third day or the fourth day, try to check if the next set of aligners are fitting. If that is fitting, then you can just continue on wearing the aligners for your patient. But if it is not fitting, please go back to the previous one and inform Smartee to produce a new set only for that set for the patient. You don't need to submit a scan for that. You will just order that particular set from Smartee. Now, that is the solution for patient when aligners crack. If it fits, then we continue wearing the next set. But if it doesn't fit, we request Smartee to reproduce a new set as soon as possible. Now, there are instances wherein the patient would wear, for example, aligner number 10 that fits well on the lower, but then the upper 10 does not fit, and they will be using the number 9 aligner. I would not recommend for your patient to be wearing different sets, like for example, number 9 on the upper and then number 10 on the lower. Make sure that you will be making them use set all the time. So if aligner number 9 on the upper is not fitting, but aligner number 10 is fitting, please go back to the number 9 set. Make your patient wear both the upper and lower for number 9, and we will have to request Smartee to produce a new set for the one that doesn't fit. For example, for the set 10, we will ask Smartee to produce number 10 set. Now, for poor aligner retention, if the clinical crown is too short or probably the tooth crown is damaged and the crown morphology is not ideal, then we will have to reinforce the retention. So what does it mean? We might have multiple attachment for retention, or probably if there's a class 2 composite that was damaged, or probably a class 4 restoration that was damaged, you will just have to put it back or reinforce the retention by making use of this aligner as a guide for you to place back what was lost. If the silicone impression is not precise enough, then you have to retake the impression and you will have to or do a scan again to produce new sets for your patient. Earlier, we've mentioned on the correct treatment procedure, right? When we submit a case to Smartee, it's either through direct oral scanning, or if you do not have an oral scanner, we take a silicone impression. It has to be a PVS silicone impression because that is more precise. If the doctor has not used it or perhaps may have used an alginate and it's not precise, then there will be no tight fit for the aligners. And we might not be able to get a good treatment outcome with that. There should be a grip in wearing the aligner. Now, for the tooth movement issues and solutions, these are the things that we need to observe. If there's abnormal tooth loose or insufficient tooth rotation, insufficient tooth inclination, insufficient tooth extrusion, or unexpected tooth intrusion. Now, for abnormal tooth mobility, we have to check if the teeth are moving in a normal, if there's tooth movement that we see, it's quite normal because we are moving teeth, then that's good. But then if we see abnormal tooth mobility, a strong teeth movement, then it means that perhaps the patient might be changing the aligners too frequently because there's an orthodontic force that's too strong, or perhaps there's occlusal interference. Earlier, I mentioned that when we see our patient, when they go back to our clinic to check the attachments, to check the fit of the aligners, we also have to check on the occlusal interference. When they remove the aligners, we have to check on the occlusal contact points. Now, if there is a premature contacts, for example, on the canines, we have to do a spot removal. You check with the, the biting paper, and make sure to remove only the one that's in contact. And perhaps, for example, you have mentioned that your patient should be wearing it for every 10 days, and suddenly your patient wants to make the treatment shorter. So your patient changes every 7 days instead. You will have to ask your patient to prolong the wearing time and extend it to perhaps 14 days. For insufficient tooth rotation, if there's insufficient correction of incisor rotation, that is because of insufficient space. So we already know that if there is insufficient space, we will just have to make use of the diamond strip to loosen the interproximal contact point so that it will help to correct the incisor rotation. Or probably you can check the occlusal interference. If there's occlusal interference, you will just have to remove the contact. Or probably there's microdontia or malformed teeth for the patient. So those are the reasons for the insufficient tooth rotation. Now, you may also use auxiliary elastics to correct the 1-2 rotation. For example, in this case, looking at the occlusal view of the auxiliary elastic, then this is the occlusal view after the derotation. You may use the elastics or the lingual button and use the elastics after you put on the aligner. So you can put on the aligner, just relieve that area where you will be placing the button on. For insufficient derotation of the canine and premolar, that is determined by the attachments. So you always have to check if the attachments are still there to derotate a canine or premolar. Now, if that is gone, you will have to put it back right away. Please advise your patient not to throw away the previous aligners because there is a chance for us to go to rewearing or go back to the previous aligners, especially if this happens. If probably it was unbonded that you have not noticed for a long time, then you will have to go back a few stages to where it fits well. And that's the one that you will be using as template. If ever there's insufficient space, then that will also be the cause for the insufficient derotation of the canine and premolar. And perhaps there's occlusal interference. Please check on the contact points And probably there's short clinical crown. That's why there's insufficient derotation of the canine and the premolar. There might be instances wherein you might do couple attachment to help with the derotation. There will also be times wherein in the middle of the treatment, you will be asked to remove the attachment and put back an attachment, but it is placed in a different location. To correct the rotation using the auxiliary elastic, you can use this one. And again, you can just cut the area where you will be placing the buttons on and put on the aligner to help with the rotation. For insufficient root inclination, that is because of poor root control. So it might be the unbonded attachment, because we have attachments for root control, like for the precision control attachment, for the vertical rectangular attachment for root control. It might be unbonded, so just make sure to put it back. And insufficient space, or probably low efficiency of the aligners. We have smart attachment S1 for root control. Those are two small attachments placed near the gingiva, and the one is near the occlusal area. So because those are small, there's a chance for you not to notice that it's gone. So you always have to check that it's there. So it's placed on the labial aspect of the incisor to make the adjustment of the mesiodistal direction movement more precise. So that is very important. It can also be placed on the buccal aspect of the canine to make the translation of canines visible. For the insufficient tooth extrusion, so again, we have this attachment for extrusion, the horizontal attachment. Please check if it has been unbonded or perhaps it's no longer the same size or the same shape. You will have to put it back using the current aligner and the one that fits well. For the insufficient space, that might be the reason also for insufficient tooth extrusion and low efficiency of the aligners. You might be able to use this 1, 2 to 8. For example, there are instances wherein everything fits well, but then only this tooth number 1, 2 is not fitting. So it's not enough extrusion. You can use auxiliary elastic, put a composite bulb, and put a lingual button. And then once you put on the aligner, you have to hook the elastics on top of that. So that will help to extrude. Unexpected tooth intrusion, if the design movement is not fully expressed, meaning to say there might be movement that were not predicted or untoward movements that were not expected, or probably insufficient space. So with that, we have to just help remove the interproximal, use a strip to loosen the interproximal contact point. So for example, there's lingual movement of the incisor that was prescribed, but no IPR is performed as instructed. It will result in the lower right canine intrusion. So you have to check on those unexpected movement. For joints clicking and aching during the treatment, we have to determine if that pain or that discomfort is normal because they are adjusting to the teeth movement or the aligner. You have to stop wearing the aligners for the moment to correct the lower joints issues if ever that the joints clicking and aching prolongs, meaning to say it's more than a week already or it's not going away. So we have to stop wearing the aligners and resolve the lower joints issues first. After it has been resolved, then the patient can continue wearing with the previous correction stage. If ever, the patient will stop wearing the aligners, and it took the patient about a month or two to correct the joints issues, and the aligners are no longer fitting, then that's the time that we make use of the refinement. We will just submit a new scan to Smartee and they will produce new sets for your patient. Now for the occlusion, we always have to inspect for the occlusion, always check for the premature contact and resistance to tooth movement, and we correct for malocclusion. So for adult patients, correction for malocclusion is very important. For the temporary occlusal interference, for example, for the first 2 sets, we do not recommend temporary occlusal interference correction. So continuous occlusal interference, so that is what will require for us to do occlusal correction or occlusal interference correction. We mainly refer to the following reasons if the rotated maxillary incisor is thick, has thick lingual margin ridges, or there's teeth-to-teeth intercuspation, but teeth movement is still required. For occlusal adjustment, we follow these principles. If the occlusal interference is too much or the duration is too much, the treatment plan needs to be modified. For example, you keep on trimming on that area or removing the contacts. Then I think the treatment plan needs to be modified. You have to submit for refinement if that's the case. You always have to inspect for the malocclusal contact points, adjust the upper lingual teeth and posterior non-functional cusps, and adjustment should be done in several times with small amount, and do not reduce the height of cusps randomly. For the anterior open bite while wearing the aligners, since aligners function as bite pads, which may cause posterior intrusion and uncertainty with posterior occlusion change, we inspect for occlusion contact point of the anterior and the posterior teeth. We correct the abnormal occlusal contact point on the posterior segment of the aligner. And for elastics-related issues, if ever we need to do traction on our patient, this is how it looks like. So normally, if you will have to do traction, there will be a cut, a reserved cut for you to place the buttons on the tubes. And there is a precision cut for you to hook on the elastics. Now, the value of force is around 100 grams to 150 grams. So it can be adjusted in accordance to clinical circumstances. If you are advised to wear, for example, 3.5, 1/8, or 1/4, you follow that, but it can also be adjusted depending on the case of your patient. We do not want to have the side effects of the elastic. So be aware of the side effects of the elastic. Now, for the post-treatment, for example, we've done all the troubleshooting. We've done all the techniques that we know, but still the aligners are not fitting. Then we have to do refinement. So, for example, your patient has gingival black triangles because your patient is not compliant with oral hygiene. And the patient had gum recession or had the black gingival triangle, you will just have to resort to this treatment. You have to place cervical resin restoration to close the gaps, or add IPR to reduce the gingival black triangle. Now, for posterior occlusion and tight or open bite, for example, the anterior teeth looks very good already, but you have an open posterior bite and the intercuspation is not good. Then you can help by using elastics, or you can submit for refinement, or you can check the occlusal interference. Sometimes that's the only reason why it's not in contact. Now, if ever it's still not in contact, then you can remove the 6 and 7 section on the aligner, leaving the 5 to 5 section, and it will help the posteriors to extrude naturally. Here are the causes of posterior open bite. It's the thickness of the aligner, premature anterior contacts, and lack of space in the aligner for arch length reduction. So if you will ask how thick is the aligner of Smartee, it's only 0.5 thickness. Cause analysis. Aligners function as bite pads, so we have to remove the molar section of the aligners, or you can use a vertical elastic, auxiliary elastic, to help to have a tight posterior occlusion. Occlusal interference. For every occlusal interference, we'll just have to make occlusal adjustment. Again, be cautious and do the gradual reduction only in small amount. So this can be done as well for passive eruption, posterior extrusion, and anterior intrusion. Just have to cut that area of the aligner and to close the posterior open bite. So that is one example on how to close it. For small space not fully eliminated, for example, there's still spacing that was not eliminated. It's still there during the treatment finishing stage. That is because probably there's impression precision error or accumulation error. Perhaps there's an IPR error or occlusal interference. So the solution for that is occlusal adjustment, or you just have to send the case for refinement, remake impression. If IPR is not properly handled, therefore the space closure is not completed. So the correct adjacency between teeth and close the space with additional aligners. Pre-refinement related issues. If ever you will be submitting for refinement, you will have to take impression again or do scanning. Do you need to remove all the attachments? It's best to remove. It's highly recommended to remove all the attachments. But if you feel like those attachments are significant, and it's significant for tooth movement, and it's still good, it's still new, then you don't need to remove it. Smartee might redesign or add some attachments to move those teeth that did not move, and you may just add new attachments if that's the case. So what should you do if there is a small space? Check whether it is a bad IPR space. For example, when you submit your refinement, and there should be a 0.5 gap between these two teeth, check using the IPR gauge or dental floss if you have enough space for that. So overcorrection is required in refinement. And what should you do if the molars have a limited open bite? Like what I've mentioned earlier, do occlusal adjustment or remove the 6th and 7th section, leaving only the 5 to 5 section and wear them for a while. After you establish the tight occlusion, then you can send already either for retainers or for refinement. So how to design refinement plan for individual tooth with a small amount of rotation. For derotation of teeth, that requires space. So you need to add a small amount of overcorrection, a small amount of IPR between the adjacent surface. You first proclinate a little and then retract after aligning. And by the way, if ever you will be submitting for refinement, you always have to ensure that your patient will wear a retainer or aligners during refinement until the new aligners arrive. You have to determine what aligner number the patient is wearing and let them wear it until the new one arrives. Now, I'm going to show you an example of one of my patients. We do strict clinical monitoring with her. This patient has a thick lip, right? And the facial profile is not that good as well. And two teeth are flared. And then after the treatment, we see a significant improvement with the facial profile of this patient. And the teeth, after correct clinical monitoring, if you can see, we're able to resolve the crossbite of the patient, and the teeth on the lower were aligned as well. And look at the arch. So in doing the correct clinical monitoring, doing the correct treatment procedure, we will be able to achieve this good treatment outcome. For a successful treatment for clear aligners, number one really is patient compliance. Now make sure that your patient will be wearing that for 20 to 22 hours a day. For the operation and monitoring coming from the dentist, that's very important and it's crucial. And also the design and the support that you are getting from your provider, and that is Smartee. And rest assured that having all of these three factors, you will be having a good or a successful treatment using Smartee. So that's the end of my lecture. Thank you so much and hope you have learned a lot today.
There's one question, Dr. Chris, in the Q&A section asking, do you let your patient wear their aligners during eating?
Oh, for the Smartee GE and the Smartee Alpha, we do not advise our patient to wear it while eating. So we have to advise them to remove it when they eat. But if your patient is using the Smartee GS, the one with the twin blocks or SGTB, then the patient has to wear it 24/7. It depends on the product series or the Smartee product series that your patient will be using.
And the next question, Dr. Chris, asking, would you please show the slide right before the post-stage treatment monitoring?
It was too quick. Okay. Post-stage monitoring. Let me see. Let me try to share my screen again here. Okay, let us go back to a post-stage treatment monitoring. Is this the one? Okay. So common issues and solutions for the finishing stage. If your patient encountered this gingival black triangle, then you will have to do this treatment for them because we cannot anymore do anything with that case. And if there's untight or open bite, then we will have to let the posteriors to extrude naturally by cutting the 6th and 7th section of the aligners, leaving only the 5 to 5 section, or you can make use of this auxiliary elastic to help with the bite.
So the third question in the Q&A section asking, when you do the refinement aligner, do you go back to complete the other stages?
Okay, now this is the thing for refinement. For example, because there is no standard rule with refinement, you can either do your refinement at the end of the treatment. For example, you are given 20 sets for your patient, and that is the one that's shown in the animation. You have finished all 20 stages, but then you have not resolved some minor issues. For example, there's still space that were not closed. Then you will have to submit for refinement. Or probably on the 5th stage, the aligners are no longer fitting. Then the other aligners you cannot use anymore. You will have to throw them away and wait for the new sets. So that's how it is.
Oh, so Dr. Chris, the one asking for the slides is he or she maybe wants to see the one before the post-stage treatment monitoring.
Oh, it's about the elastics, right? Yeah. So for the elastics, normally, you will be asked to place button, but then there's a new feature of Smartee, by the way, that the Smartee button is integrated into the aligner. But again, it's case-to-case basis. There are instances wherein that button cannot be placed. For example, if the condition of the periodontal condition of your patient will not make it good for that button to be placed, then they will not be placing that integrated button. They will be recommending for you to place the lingual button, the metal one, for traction. Now, they will be relieving that for you. They will be putting a cut on that button so that you know where to place the button. Do you want to see the picture of that? For the post-stagement. Okay, this one, right? For the elastics related issue. So the rubber band elastics can be adjusted depending on the clinical circumstance. For example, 3.518 is too small, or perhaps it always, it's not retentive. Then you can use perhaps 1/4 so that it will be easier for this patient. So we don't want any side effect of the elastic. So be aware of that. You always have to check whether your elastics is a bit strong, then you have to make adjustment. We don't want this side effect. So the one I've mentioned, Smartee will be relieving a cut, reserve a cut for you to have a guide to place your button. And there's a cut here as well, a precision cut, so that you can hook on the elastics to it. Now, there's a technique for your patient because it's quite difficult to hook on this precision cut. You can have your patient hook the elastics already on this precision cut before they wear it. After hooking it here, they will just wear the aligner, and then they will just have to pull this elastic going to the button. And that's the best way how to place the elastics.
Thank you, Dr. Chris. All right. And we got one question in the chatting box asking, what's your retention protocol?
What is your retention protocol? Okay. Now, the retention protocol, you normally for aligners, it's really tight fit. Now, our protocol is to ensure that we are sending a precise impression, or our scanning is really precise. Because if it is not, then the aligners will not be retentive. Of course, Smartee will be designing a retention attachment to help. It really depends on the case. But then that is the protocol. We have to ensure if we will be sending an impression, like a PVS impression, that all the margins are intact and it's a continuous margin. And normally, if you are sending a case to Smartee and they will see that there are inconsistencies with the margins, for example, you will be receiving a notice of disqualification telling you to either send a new one to make it more precise, because the key to the success of the treatment is really on precise diagnostics. Yeah, we have another question before we go. So there's a question, if the treatment plan is not advancing properly and it is needed to perform an extrusion, for example, could the doctor ask for an extrusion, for example, in an incisive tooth? Yes, actually, if ever that you need to have or to modify the treatment plan, there is a 3D control or doctor control section wherein you will be placing your comments for what you want to achieve, especially during refinement. So we can always modify the treatment plan according to the needs of your patient.
All right, so thank you, Dr. Chris, for your great lecture today. And thank you for joining us in today's webinar. But before we finish off today, I'd like to take you through our upcoming webinars as well. All right, so those are our upcoming webinars in December, brought by Dr. Anas, Dr. Jiang, and Dr. Wang. Yeah, for those 3 lectures. And if you want to follow up for the latest information on Smartee and on our webinar, please feel free to follow us on those social accounts, Facebook, LinkedIn, and Instagram, at YouTube as well. So yeah, so thanks everyone for joining us today. And
I'm sorry,
thank you again,
Fiona.
Dr.
I'm
Yes.
sorry.
Thank you, Dr. Chris, and thank you everyone for your continuous support to Smartee. And that's it for today. Please enjoy the rest of your day and or night. So we look forward to seeing you at our next webinar. Goodbye, everyone. Goodbye, Dr. Chris.
Bye. Have a good evening. Bye.